we're now going to move to our next session that is going to be directly about what the Beacon communities are doing and how they're addressing these kinds of priorities. And to lead that, I'd like to introduce my friend and former colleague, McKethan, who is the National Director of the Beacon Initiative. Also, while we're making this transition, this might be a good time for those of you who are standing at the back. If you're doing this to get exercise, that's great, but there are a few open seats here down near the front, so please feel free to come up. Thank you all very much.
Good morning, welcome everyone. As the next panel gets set, I'm going to frame the discussion. We're going to hear from some of the Beacon communities. We'll pause so the folks on the webcast can hear. Oh. Okay. All right. Thank you. Everybody hear me now? We were talking about IT today, so it's good to have our IT systems in place. Well, welcome and good morning. I'm going to offer a few framing remarks for the leaders here at to my right, who are going to share their early experiences with the Beacon Community Program. The 17 diverse communities that participate in the program, from Maine to Hawaii, have three key aims. And we've heard about many of those this morning, and I'll just reiterate them to frame this discussion. The first aim is to build and strengthen the local healthcare IT foundation to support the kinds of capacities that were being discussed in the past session. So, for example, the ability to collect data from multiple sources and use that for performance measurement feedback systems for healthcare providers and the public at the community level is a critical piece, both to enabling short-term improvement, as we're going to hear today, but also about enabling the kinds of payment models that are going to depend upon that kind of data and that kind of performance improvement. So aim one is to build and strengthen the capacity of using IT and expand it more broadly. The second and most important aim, though, is about using that infrastructure today to achieve specific improvements in health and healthcare now, not to build a system and hope that it all works out, but to be building the system while you're at the same time aiming for specific concrete improvements in health at the local level. Now, ONC, when we established the program, we did not assign those objectives or assign those specific performance aims to individual communities. We said, no, we'd rather hear from you. What is the most important healthcare issue in your community that you want to address using health IT? So the second aim is about improvement, using the tools that you have now to demonstrate improvements in care in the next several years. And the third and related aim is about innovation. It is about, as far as I'd mentioned, that beacons are like jazz bands. That involves improvisation and learning as we go and riffing on new themes. And so the beacons have a goal in mind, but the path to getting there is going to require learning and refining their strategies as they go. So they have an obligation to take advantage of early lessons for their own sake, but also to use it to make available to other communities as we discover new things about the combination between IT and care redesign. So this is the one-year mark, and we are not here to unfurl a mission accomplished banner. This is just the beginning, the end of the beginning. But the communities have hit a really important milestone for setting the stage for what's to come. We're going to talk a bit today about what that first year has meant and what the next year and the next year after that will look like. After setting the stage, the period that we're entering now is really about large-scale implementation. So you'll hear now about the specific plans for taking initial pilots, initial tests of change that have been done in the Beacon communities and scaling them up gradually over time and seeing the kind of data flowing back in to help us guide our path and refine our strategy as we go forward. The later stage of the program, when we really start to see and have better confidence about the data, suggesting we're really making an impact, accompanying that effort will be really doing more on dissemination, helping discover and share with other communities around the country what we're learning. What we're learning about the effective ways to avoid complications related to care transitions as patients migrate from one care setting to another. Effective ways to help physician practices take advantage of the IT tools available in electronic health records and information exchange and so on. So we're finished. We're finishing with the setting of the stage, and we're ready for the implementation. But before we get there, let me just tell you 6 things briefly that I think comprise the setting of the stage. What are the 6 things that the communities have been mostly focused on in the first year? Because I think it's instructive for other communities that are in the same journey. We had about 130 or so applications for these 17 beacon slots. We know there are far many than that, communities around the country that are really working to leverage all the IT investment that's happening around the country and finding ways to use it effectively for care improvements. So I think it's important that we define what these sort of steps have been in the first year of the Beacon community. Now, we documented these, by the way, in a health affairs paper recently. I think you have it in your packets if you want more details. But I'll just briefly run through these 6 elements about setting the stage for what's to come. First, the communities had to really carefully design who the community is, who lives in our community, what are their most pressing healthcare issues, and how do we design strategies to address them. The second is governance. Now, anyone in here would agree that you need really strong systems of governance to carry out any kind of activity, but that's particularly the case in a community-level activity for which there are multiple stakeholders and multiple interests. So this is an ongoing triangulation exercise of really trying to decide together where we're headed as a community, keeping the patient at the center. So governance and leadership have been really critical early actions of the beacons, and they'll be as well ongoing. Farzad mentioned the importance of deciding what you're going to focus on, deciding on a few key objectives. You can't do everything, even if you have a lot of money and lots of people to help. You really have to decide what are the really 2 or 3 or 4 things that we really want to take a bite out of in this Beacon project. So we see examples. You heard Anish talk about an example in North Carolina where there's an effort in the Beacon community to really reduce the complication for patients, particularly kids, with asthma. So asthma, a couple other things comprise their main objectives. Deciding together on what those are, deciding on what are some performance measures that we can use to track our progress achieving those objectives. So it's deciding on the measures, it's agreeing on how to collect the data for those measures, and how to use that information to guide further implementation. And the communities themselves are using their electronic systems to report on a quarterly basis their progress against those measures. So we're just now getting the initial waves of baseline data. In addition, I'm pleased to say that we will be augmenting the community's own clinical data with claims data from CMS starting this summer. So we'll have reports for physicians and for the community leaders to get a view of how things are going from the perspective of readmission rates and emergency department visits and other kinds of prevention-oriented indicators, all together in support of not just evaluation, but in support of active improvement and refinement. Mark later will talk a bit about some engagement with commercial carriers to have similar and consistent measures to align the disparate data systems and align the disparate measures that allow us to really have more confidence about the degree to which our interventions are adding up to achieving our goals. Fifth, and only fifth into a list of 6, do I talk about IT and interventions. Those first 5 elements are really critical, but now after thinking through all those issues, the communities were able to identify what are the key interventions, the IT plus the process improvements that are enabled by IT, that are going to have the biggest possible impact on achieving those community objectives. So the communities range, the communities were able to define their own interventions based on the performance measures and community objectives they've established, but there's a lot of similarities. A lot of communities are really focused on how do we support better coordination of care for patients facing multiple chronic conditions. In particular, we have 12 Beacon communities working on care transitions as patients are discharged from a hospital. What happens to that patient next as they go to the home environment? Who's going to help them think about their medications and ensure that there are not any adverse effects of medication errors? who's going to ensure that they have a connection to their primary care physician. So if they have a problem subsequent to being in the hospital, they don't have to return to the hospital to get that problem resolved. So those are the kinds of interventions, there's a whole range you're going to hear about today. And then finally, riffing on this notion of jazz band improvisation, the communities have thought through prospectively, how are we going to learn about our early results, and how are we going to share that information to support later implementation in year 2 and year 3. So how are the first cohort of physicians or hospitals going to actually help the subsequent cohorts learn what's most effective, how best to use registries and electronic health records, how best to use performance information to derive improvements, how best to think about steps necessary in a care transition, and so on. So those are the 6 setting the stage elements. Several of the communities, I think over half the communities are now in implementation, but the rest of this year will be about turning on the interventions and collecting the data to really inform how we're doing. So with that, let me now turn to our panel and have you hear from them directly about how it's going, how those key elements have played out in different communities. I'm going to list off the panelists, and they'll go in whatever order they like. They'll each talk for just a few minutes as the last panel, and we'll save some room for discussion at the end. First, we have Mark Bennett from Health Insight in the Beacon community in Salt Lake City. Dr. Ted Chan from the University of California at San Diego, who's leading the San Diego Beacon community effort. Sherry Reynolds from the Beacon community of the Inland Northwest. Sherry is a twofer because she's not only part of the advisory and governance board of the Inland Northwest Beacon community, which is in eastern Washington and western Idaho. She's also a national expert and thinker and speaker about effective strategies to engage patients and keep patients in the center. So we have a twofer opportunity here. Another twofer is Julie Shills. Down in the middle there, Julie not only leads the clinical transformation activities of the Colorado Beacon Consortium, but she's also a co-chair of the overall care transformation work for all the 17 beacons. And finally, we have Dr. Herbert Smitherman from Wayne State University, who is a co-board chair for the Detroit Beacon, the Beacon community in Detroit. So with that, I don't know if you all flip coins. Who wants to lead off?
I think I was given the honor of going first. And first of all, I just wanted to say happy birthday to all the Beacons, both online and in the room. I've heard that nobody ever raises their hands at Brookings events, so I'd love to see a show of hands of who in the audience is actually with the Beacon community. Well, happy birthday. I mean, absolutely happy birthday. 8 minutes isn't a lot. I thought 8 minutes, fly across the country to talk for 8 minutes. Why would somebody do that? You know, I mean, people on the plane said, "You're doing what?" And I realized the average doctor's visit is about 8 minutes. And we ask providers to bring about change in a very short period of time. So I said, sure, I'll do it. I love to go to DC. Aaron warned me to not be disruptive because the last time I was in DC, I ended up on my back underneath a police horse because I came out the wrong door of a hotel. So he said to not stand up. I love the comments earlier where we talked about angel investing. I'm a social venture broker. What that means is I don't have the money, but I have friends who have a lot of money, and we love to start new companies. And I really view ONC as an angel investor, and these 17 communities as startups. And like most startups, in the first year, it's pretty chaotic. And what you thought you were going to do isn't probably what you're going to end up doing. And at some point in this process, you'll turn around and look at one another and say, you know what, who's our customer? Who are we building this for? And when I was on a plane for 8 hours yesterday, and you get to think about planes when you're on a plane for 8 hours in a thunderstorm. And I realized that sometimes, and I'm from Seattle where we build planes, we love to build planes in Seattle, that sometimes we get so caught up in building the plane and making this really amazing cockpit that we forget to put the seats in the back. And so it's everybody in the room remembers what we're in healthcare for. There's no question that, you know, this is the cream of the crop in terms of policy, in terms of implementation. But it's critically important that the Beacon leaders always remember the voice of the patient. And that doesn't mean putting somebody like me on every single committee, although that's a start. It's really a start. What it really means is patient-centered design. And that's a core value. And we all know that. We all know the first 5 pillars of IOM, but we occasionally forget that this is really about the patient. fact, I think if you really want to have a quick solution to the escalating cost of healthcare, just eliminate the patients. I mean, that would solve the problem. But we don't have that as an option. So my role, obviously, is to focus on that critical importance of doing patient-centered design and including the patient's voice in everything that we do, in every meeting that we do, and every policy. Now, I'm trained as an engineer originally, and so I understand scope creep, and you guys are pedaling as fast as you can. And so how can we do this? Just give me some practical little cycles of change. Sherry, I need to know how I can go back and do this tomorrow. Simple things. What's your website look like? Have you had any patients look at it? What's your communication strategy look like? Have you had any patients review it? We all know how to do these things. What we need to do is have it as your core value. Now, some people say, well, ethically that's what we should do, but there's a really strong business case to be made for this as well. I don't know if some of you saw the study last week. I think it was an AHRQ study. 29 patients, congestive heart failure, 10-year project, and they have a telescale. And it wasn't the technology, it's the care surrounding the technology that was critically important. And they cut readmission rates, which typically run 40 to 50% for congestive heart failure, to 2 to 3%. The savings for 29 patients in 6 months was $1.9 million. So this, if you want to just be hardcore business and you want to save money in your communities, I'm sure if your state is like mine, we're cutting budgets left and right. So if you can come with a solution to the state of saving them money, providing higher quality health care for your community, people are going to listen. So this isn't just like an extra. After we get the project up, then we're going to engage the patient. The patient needs to be at the table during the design stage, at the table during implementation, and driving engagement. So we also need to shift from building location-based healthcare to healthcare that's technology-enabled. What that means is technology allows you to break down the walls of your provider's practice. It allows the patient and their family to engage when they're at home or at work. I had a situation recently where I had to go to Boston. And the night before I needed to go, I thought I had an infection. The flight didn't leave till noon. So I picked up the phone and called, consulting nurse, no problem, pulled up my records online, said, we can send in the prescription. I said, I'm sorry, I'm going to be in Boston. And they said, not a problem. Next morning, the doctor authorized the prescription and sent it to the Walgreens in Boston. I never saw anybody. I just picked up the phone and called. Everybody should have access to that kind of care. And this was not, many people know I used to work at Group Health. I often talk about integrated systems. I'm no longer in that. This was just my community in Seattle have got the pieces together in order to bring this to individual patients. And I'm on the advisory board, and I was not only on the advisory board, I was on the committee that drafted the application. So at INHS, it's a core value to always include the patients. I sit on the advisory board, and I can say, I think we need a communication committee or an engagement committee, and then one appears. These are doable tasks. On the brand new website, I don't see Jack, there's Jack, in the audience from INHS. On the very first page is a video of a patient talking about their experience. Everybody can do that. These are attainable goals. I think that when you look at your metrics, and I would encourage ONC, when you look at how you evaluate how the money is being invested, and I do believe that this is an investment, that you take a look at investing in your patients as well. This is an expensive work, but it's critically important work. And I'm actually not going to use all of my time because one thing that I'd love to model is that sometimes the people in the audience are just as smart as the people on the stage, in the same way that sometimes the patient has just as much information as the provider, and we need to make the space and make the time to hear that voice.
Great. Thank you very much, Sherry. Sure. Dr. Chan, you want to?
Sure. I represent the San Diego Beacon, and we've had an exciting year, challenges and as well as successes, I think. Just by way of background, San Diego is about 3.2 million people. It represents about 1% of the U.S. population and has the same sort of ethnic diversity as the rest of the country. Our healthcare marketplace is very competitive. We have a very large Kaiser system. We have two very large integrated systems, Scripps Health and Sharp Healthcare, as well as the university. We have a very large VA and DoD population. We have either the second largest military hospital in the country. One of our challenges is some of these systems are very well integrated, and how do you get them to engage in a community level effort when they're most concerned about market share and how they protect that market share or grow their own market share. And one of the things this year that we've been able to do is use actually data that we've collected as part of the Beacon process to convince these organizations that in fact to move any metrics, you're all going to have to work together. One of our goals is 30-day readmissions. Well, it turns out when we pulled the data on unanticipated 30-day readmissions, 25% of those 30-day readmissions occur at a different institution than the initial admission, which means that if you're going to address this problem, whether you're Kaiser or another large integrated system, you will have to work together to address that problem, since 1 out of every 4 of your 30-day readmissions are occurring at another facility where you may not have access to data or the patient's records or that sort of thing. So that's been one of our target goals, is looking at 30-day readmissions, and using that data has really brought our organizations together. And now actually we have a place where all our organizations get together. It's called the Preventing Readmissions Network. They work on issues such as developing a community-wide discharge standard and checklist that will run across all the institutions. We're working on systems of messaging within a health information exchange. We do know that getting patients back to their primary care provider within a couple weeks of hospital discharge is a key element to reducing readmissions, hospital readmissions. And then linking to the VA and DoD in particular, because we do know that those patients in particular move around to different facilities despite having a very large VA and DoD hospital. One of our non-DoD institutions had something like 15,000 visits from DoD patients in a year's period of time. So using data to show that patients actually move around and they get care from different facilities and different sites has really convinced competing organizations to work together on this issue. One of our other goals is looking at immunizations, and here we're working on a sort of a provider and patient engagement and using technologies to engage at a higher level. We have a pretty robust immunization registry in San Diego, and what it shows us is that from the ages of 1 to 3 years, our immunization rate is only about 47%. That those kids are up to date on immunizations. Now, this has a lot of downstream effects, not just on the kids, but last year we had a whooping cough outbreak. I'm an emergency physician. I can tell you that lots of patients came to the emergency department because of a cough or a viral syndrome, worried about whooping cough. I ended up doing more tests because of that, and I ended up probably giving more antibiotics than was warranted. So here's a preventable disease that really, if we had robust immunizations in our community, we would also prevent all the worried well from taxing the healthcare system. Finally, our third goal is really engaging EMS. There are 200,000 911 calls in our community. That has downstream effects to more emergency department visits. About 20% of emergency department visits are a result of 911 calls. That has downstream effects on hospital admissions. We're looking at wireless transmission of patient records, not only to improve care in the field so that information about patients is available to the paramedic taking care of that patient, but also sending information all the way upstream electronically to hospitals. And the one we're focused on is EKG transmissions to gateway to hospitals to improve cardiac cath times for patients who are having heart attacks, and more importantly, to reduce the false positive rates of activations. 1 out of every 5 activations from the field for a heart attack is not truly a heart attack, and that's lots of resources that hospitals are spending that they don't need to. So I see that I have about a minute left or so. I want to share one anecdote related to the EMS space. We actually have been beta testing our system, and we have been training our paramedics in the field on the system. We haven't turned it on completely yet because we haven't finished our training, but there was a patient a couple weeks ago who was having a heart attack. The EKG showed that it was one that would have should be treated quickly in a cath lab. It was the battalion chief and the paramedic who said, "We know about this technology. We want to push this." They called the base hospital nurse, pushed the EKG electronically through wireless technologies to them, and then that base hospital nurse pushed it to the rival hospital, actually the competing hospital, who activated their cath lab well before the patient ever arrived. And what I like about this story is that the IT was just a tool, but it was actually the paramedic and the battalion chief who said, I know about this tool, I know how to use it, I can see the link to improving the care for the patient, and I'm going to push this. I'm going to push us to use it, even though it's only in beta testing, before it's really completely rolled out, because I know it will impact this patient's life and this patient's care. So I'll end with that.
Thank you very much. That's great. I was just in Colorado last week. I can tell you something's in the air there in western Colorado, Julie. What's going on out there?
We're working a little bit. I'm Julie Shills, and I'm honored to be speaking on behalf of the Colorado Beacon Consortium. One thing I wanted to say before I get started is I'm a quality improvement geek, and I've been working in the primary care setting for about 15 years. And one of the things that I've appreciated about being part of the Beacon program is a term that's used in Japanese quality improvement, and that's Gemba. And my translation of what Gemba means is go to the people who are doing the work every day and figure out what the solutions are with them, instead of deciding and putting those solutions upon them. So we all feel incredibly honored to have the ONC go to the Gemba and to work with us to create the solutions that we need and to create a healthy healthcare delivery system. I've also had the pleasure of working with the other Beacon communities and learning from them, as Sherry mentioned, true experts and innovators in the field, and it's a great support group out there. So Colorado Beacon Consortium is a group of individuals that actually started coming together 30 years ago. And it's the hospital system, St. Mary's. It's the nonprofit health plan, Rocky Mountain Health Plans. It's the physician organization, Mesa County Physicians IPA, as well as in those groups really coming together to care about the citizens in the community. And one of the things that they did several years ago, the journey started about 10 years ago, they thought, well, we really need to have information available in our care delivery system. And that's when Quality Health Network, the Health Information Exchange for the Western Slope of Colorado, was born. And we are lucky enough to be able to work with the Health Information Exchange that's been in the community for 5 years. And through their efforts in their arm of the Beacon community, they're working on enhancing the work they've already done and making data available for the community. And my side of the work is in practice transformation and working with practices in a way that they can use the data for knowledge. The community in western Colorado, we are focusing within 7 counties. It's an amazingly geographically diverse community in which you have high desert mesas and the majestic Rocky Mountains. Within these communities, we are considered to be frontier and rural, and then one of our communities is more urban, and that's in Mesa County and Grand Junction. So why do we go to work every day? Well, our hope and our goal and what we intend to accomplish is to improve the quality of care that's delivered to all citizens in the 7 counties that we're working with, and to also improve the health outcomes of those citizens. We're focusing on chronic disease, both children and adults, in the area of asthma, cardiovascular disease, and diabetes. And through the efforts and what we're doing there, our hope and goal is that we can impact some of the utilization that's happening that's costing our community dollars that don't need to be spent. So working towards an effective ambulatory care delivery system in which we're decreasing readmissions to the hospital, readmissions within the hospital system, as well as hospitalizations and emergency room visits. So within this, within the work, we also felt it was important to bring in prevention and wellness, because what we wanted to do is stop the influx of folks who are diagnosed with chronic disease by focusing on lifestyle changes. So some of our efforts as well with primary care practice is focusing on smoking cessation, screening, obesity screening, depression screening, also breast cancer screening, to start to engage in practices and how they can support the journey of communities becoming healthier. These efforts were also important, and we think it's important to work for every citizen in the community and provide the same level of care for all, not only whether you have insurance or do not have insurance, or whether it's Medicare or Medicaid, or whether you're underinsured. We hope that these efforts really are community capacity building. So what are we doing? We are implementing IHI-style breakthrough series learning collaboratives and quality improvement advisors to work with primary care practices across the 7 counties. These primary care practices are pediatrics, internal medicine, as well as family medicine. Our goals and the work at a high level of what we're doing with the practices include supporting the practices and developing their team, working towards utilizing their technology, whatever they have in the practice, to use registries, to learn the principles of performance improvement, creating your team, understanding your population, implementing the evidence-based guidelines, using your registry to show you your data so that you understand your plan, do, study, act cycles, and how they're supporting your patients in your care delivery. So really starting to think about, and one of the joys in the practices is that they're actually starting to be hungry for data, and they're starting to learn how to use data, and they want to use it to improve their outcomes. So our goals within these 7 counties is to work with 75 practices. We started with 15 practices in our first cohort last fall. They had a learning collaborative, as Erin mentioned. We added 13 additional practices just this past Friday. And one of the amazing things that happened, I'll end with a few stories in that work, is that the practices are building their own community. I had several physicians come up to me and say, I love going to work now. And that is incredibly powerful. They are using their team. They're maximizing their technology. Other practices said, you know what, we were getting faxes. And we stopped and said, we actually have an electronic health record that can help us with fax server technology, and we can get that information in our electronic health record. So they called up their practices who kept sending things through the fax and said, use this number. And they decreased the number of paper, so that actually helped them with their bottom line, and it helped them become more efficient. The other story I want to share, as Sherry started off our efforts, because this is about being patient-centered, is one of the things I was thinking about, what should we do for our next cohort, and what types of things should we introduce? And it was really about having patient engagement and having patients, whether it be through surveys or whether it be through an advisory board or patients on your quality improvement team. I had practices come up to me and say, Julie, you know, the next thing I want to do, we need to have patients on our quality improvement team. So we're running after them now. They are doing the work, they're doing amazing work, and our goal is to help them be successful in the work. This is a journey. The one thing we tell them, this isn't a project. Even though this leg of the journey might end in 2013, the journey of quality improvement and bringing value to the community, that is work that never ends. So with that, I'll pass it along.
Thank you very much. Bennett?
Thank you. My name is Mark Bennett. I'm here representing the Utah Beacon community. Our community is actually the Salt Lake Metropolitan Statistical Area in along the urban Wasatch Front in Utah. Our community has about 1 million people in it that we're trying to serve through this Beacon initiative, and we're focused primarily on diabetes care, and I'll come back to that in just a minute. The Beacon initiative is actually a consortium. Health Insight, the organization I represent, leads that consortium, and our role in the community is as an aggregator or a connector. We bring people together and we try to help create greater efficiency and effectiveness in many of the different initiatives going on in our community. In those roles, we serve as a regional extension center for the Office of the National Coordinator. We are a contractor with Medicare as a quality improvement organization, and we are a regional health improvement collaborative chartered value exchange working with the Agency for Healthcare Research and Quality, among a number of other roles. Other members of our consortium include Intermountain Healthcare, very large, clearly capable health information technology expert organization that provides almost 50% of hospital care in Utah and a large part of primary care within the state as well. And the University of Utah, also an integrated delivery system fairly advanced in health information technology. The Utah Health Information Network, which is our health information exchange in the state, it's been established for a long time, and I chair the board of that organization as well, and the state of Utah. Those consortium members are working towards a goal. Our primary goal in terms of diabetes care, our long-term vision, is to eliminate emergency department visits and hospitalizations that are due to uncontrolled blood pressure, blood glucose, or LDL levels, or are associated with lower extremity amputations. And so that's what we're trying to accomplish through the Beacon Community Initiative. We have other goals beyond that, but we're focused on, in the interim steps to achieve that longer-term vision, on improving preventive and care management processes associated with diabetes care in about 70 clinics in our community. These are clinics that are already using electronic health records and are, because of that, presumably have significant capabilities. Primary interventions that we are working on at the community level include referral and communications improvement, particularly trying to make information flow more effectively from one provider to another. Clinical decision support tools. We have a tool that was developed by Intermountain Healthcare that we are scaling to the broader community for managing diabetes care. We're implementing portals in most of the practices that are participating for patient self-management, as well as care management tools for high-risk diabetic patients, and use of care managers. And we're using EHR-driven feedback loops, patient data feedback for performance in the communities. Our strategy initially has been to work with each of these clinics on assessing where they are and identifying the gaps and understanding better how those gaps can be filled. Of the 70 clinics, we've finished the assessment phase with about half of those, and more than a dozen of these clinics have already set new goals and redesigned began the initial work to redesign their processes. I wanted to just end my time with just a couple of stories about how those clinics are doing that. The first one is a small clinic in Salt Lake Valley that has used an electronic health record for more than 10 years. And when they started participating in our project and came to the first learning session, they figured out that they didn't have any way to get any data out of that record. They have it in their system. So we, through other projects we've been doing and been able to sort of combine that assessment with work we're doing with the regional center, we were able to help them get the first registry data out of their system, put it to work. This is an older electronic health record system. It's not certified under the meaningful use criteria, so it's got some limitations to it. But they were able to pull data out of it and immediately produce 20 additional appointments for patients who had diabetes that they didn't know about, they weren't tracking. They were able to schedule those appointments and begin to see those patients to begin to help them control their diabetes and better manage it. The second story of a number of these is a small clinic, again, that came into this process without really any knowledge of improvements. So by attending our improvement sessions, they've been able to immediately gain some energy and start into figuring out, how do I actually do a PDSA? How do I change some process within my care system? Our fundamental belief about this process is if providers don't know how to change something, then nothing will change. So the adage that if we don't start by changing the system, then we're going to end up with the exact same results we've had before. And so by just teaching simple PDSA principles, this practice was able to immediately redesign their flow related to treatment of diabetic patients, so that they saw every diabetic patient who now comes in the door is instructed to take their shoes and socks off. They have a process for managing recall and bringing back those patients more effectively. And they have energy and excitement about the Beacon program. Between the first learning session and when our staff went back, immediately when they showed up, they'd made 3 changes, And we thought we were going to come in to sort of get them started, and they were fully energized and ready to go. The doctor and the MA had a new process for how they interacted with the patient, how they extracted data from their electronic health record. Those kinds of stories are the early evidence we see of real change happening in the community around our goals.
That's great. And Dr. Smitherman, last but not least.
Thank you very much, Aaron. Thank you again for inviting me. Just a few seconds about myself so you understand the context in which I'm speaking. I'm an internist. I'm a primary care physician. I'm also a member of Wayne State University faculty. I spend about 70% of my time practicing, seeing patients, 30% involved in administration and seeing and educating residents and medical students, et cetera. My patient population is about 25% uninsured, about 50% Medicaid, and 25% everything else. And I'm pretty excited about the Beacon project, but I'm going to sort of give you that, let you sort of understand the journey of how I got there. First of all, when I heard about this and understand the country's littered with HIE products that nobody's using. So, you know, my issue was just put the boxes and the wires and the connectors together and let me know when it's done. And we'll see if it does anything. But I went to the New Orleans meeting, and I think it was really very important to understand that this was not an HIE or an IT project. It was a clinical transformation project. It really was about moving the healthcare outcomes needle for this country. And I got very excited about being a pioneer involved in moving health outcomes forward. Now, let me tell you, as a practicing physician, I can tell you firsthand the system's crazy. I will have a patient, let's say Mrs. Jones, and Mrs. Jones was in the emergency room at an institution a week ago. She was at her cardiologist at another institution, this is a real story, and who had done some diagnostic testing and imaging, and also changed some of her medications. And now she's seeing me in my office, and I'm blind to all of that. And I'm being asked to make a decision about that patient. Now, I don't know how many people in here or what industries you're in, but trying to make decisions when you have only a part of the data makes no sense. It's poor quality. It makes no sense for our patients. It's extremely frustrating for the providers. So when I hear a process where we're going to be able to have perhaps a health delivery system that's better informed, and we can make better informed decisions about patient care, that's very exciting for me. It will make my day better as a practicing physician. So, but let me give you a little bit of context, because I think you have to understand the challenges. And this is, as Aaron and Farzad said, this is extremely hard work. If you look at my community, my Beacon community, Michigan has the highest unemployment rate in the country. It's about 14%. Nationally, we're about 8.8%. My community, the state of Michigan, has a population of about 3.3%, but we represent 28% of all job losses in the United States. The county that Detroit sits in, where our Beacon community sits, is 1% of the population, but represents 6.6% of all job losses. Detroit has a 28% unemployment rate, and if you look at those who have stopped seeking work, it's about 44% unemployment rate. And 2 out of 3 causes of death are either heart disease, cancer, stroke, COPD, or diabetes. And if you look at diabetes, 28% of all discharges from our hospitals are due to diabetes. We have a 69% preventable hospitalization rate, higher preventable hospitalization rate compared to the rest of the state. And for diabetes, it's 132%. That's hard work. Our project is about changing that needle. It's about moving patients and moving those indicators in a significant way forward. It will not happen with paper charts and our current system. It will not. I don't know whoever is thinking that in the United States is living in a dream world. We have to change the way we do business. And so the question is, how do we engage our community? How do we engage our country? How do we engage our patients to make that change? That's really what our fundamental question is. What our project is about is, quite simply, we're going to start with enrolling 4,000 diabetics. Our goal is up to 29,000 diabetics. We have 93,000 diabetics within our community. We're going to engage 163 providers, which right now we've already engaged 100 of them. There are going to be 36 practices. We've engaged 28 of them. Half of them are federally qualified health centers, and we're engaging 10 emergency rooms. Our interventions are, we're talking about care coordination, both patient navigators in our emergency rooms and outpatient, clinical decision support, workflow within our practices, making sure we're able to mine that data and get it out, and use of EHRs within our practice. Mobile health technology, like cell phones and texting to give information to the patients. I always say, I get a text from my veterinarian about bringing my cat in, but I don't have a way to get to my patient to let them know about their patient visit. We want to decrease ER utilization tremendously. We want to decrease readmissions and by 5 to 10% over the next year. And clearly, the last indicator we want to decrease is disparities. We want to actually eliminate disparities within our community. Our biggest challenge is we don't have an HIE. And so right now in this process, and our anniversary, actually, we're one of the beacons that were in the second round. Our anniversary is actually September. So we're actually still sort in an even more compressed time frame. But we are trying to just make sure that the decrease in emergency room use, readmissions, disparities, and elimination of disparities are critically important objectives for our Beacon project. It is hard work, and we are definitely committed and excited about moving the healthcare needle and creating a better informed healthcare system for our patient population.
Thanks a lot. Well, thanks to all of you. I think the panelists are tired of hearing questions from me over the last year, so let's immediately open it up to questions from the audience. If you'll stand and make some noise, we'll get you a microphone, and make sure you're talking to that so the folks on the webcast can hear your question.
Hi, that's fantastic. Thank you for the stories and all that you guys are doing. My name is Mike Coletta, and I work for the National Association of County and City Health Officials. I was really intrigued about all the population health stuff you guys are talking about, and I'm curious if, and if so, how you're engaging with your local health departments.
I didn't cover sort of the background of INHS, but not only the county health department, but the Washington State Department of Health sits on the advisory board. And so she's right at the table. And that's intentionally, by design. And again, credit to I refer to the founders of INHS as the midwives. This is going to happen one way or another, and our job as a community and as technologists and care providers is to make that transition as easy and gentle as possible. The baby's coming, and you can have a C-section or it can be a natural birth, and our goal is just help you breathe through this process as gently as possible. And so it's critically important to not only have the Department of Health there, but the missing player is often employers. Employers in this country, in many cases, are self-insured. And so if you can bring the payers to the table as well, that starts to put in place the collaboration that's going to be necessary to move this to the next step.
In San Diego, our county director of Health and Human Services agency is on our governing board, and we have a very tight role with them because they are sort of the agnostic middle ground between competing healthcare organizations. So they play sort of a neutral party role, which is very, very helpful to us. They also run our immunization registry and some of the public health surveillance, which we're linked to as well through our HIE.
In Colorado, our community representation is a member of Club 20, and that's an organization that expands all of the western slope of Colorado. They not only have input into healthcare, but transportation and education and public health and water and safety. So they have a vast reach in terms of the presence that they bring to us. In terms of working with our public health department, we started off to kick off our learning collaboratives with our primary care practices so quickly that we're now, because of the practices and they're engaging in their community, that's how we're backing into local public health departments. One of the things that's happening in Mesa County is a funding for care transitions, Eric Coleman's care transition model. So we're starting to have dialogue about how, when you're working on care transitions, can we back into that prepared practice team who's ready and engaged for those patients who have been activated in the healthcare delivery system. And just next week, this is really exciting, in Glenwood Springs in that area, the Parks and Recreation Department want to work with the Coalition for Older Adult Wellness, who have the Healthier Living Colorado program, and work with Beacon and the Beacon practices in that community and start to figure out how can we do some wellness work in the community and move this work together.
In our community, the Department of Health is a core member of our consortium and a leader in the diabetes control program and helping us support the development of a common protocol for management of diabetes, as well as a major participant in other interventions related to public health surveillance and reporting electronically.
We have two health departments. One is the Detroit Health Department and the other is Wayne County. Both are on our board. They are heavily involved in the process. Actually, our Detroit Health Department has actual primary care services, so not only does it provide basic public health services for our community, it also provides safety net primary care services, which include free lab and free pharmacy, which are very important for us to better track and better understand the utilization of those resources. So they are very, very involved.
Thank you.
Hi, I'm Dina Peskin. I'm with the Health Resources and Services Administration. I actually have two quick questions. The first relates to workforce, especially since we've heard about primary care here. What do you see the impact of what you're doing on, in essence, improving the recruitment and retention of primary care workers in your community? Because as we know, part of the issue for primary care is not simply training, but actually creating work settings that are attractive to maintain primary care. That's the first question. And then for Mark Bennett, I was wondering in terms of your outcome measures, why you didn't look at diabetic retinopathy and prevention of blindness as a part of one of your outcome measures.
I'll start by saying retinopathy is one of our measures. It wasn't one of the sort of core measures associated with eliminating all in our vision. But it is one of the measures we're tracking. We're actually already seeing significant improvement in referrals and management of those referrals to ophthalmologists as part of our early effort. And then I'd like to respond to your other question. I think in our community, the kinds of changes we're making in the Beacon Project, the redesign of primary care, is re-energizing primary care, making it a much more attractive place to work. I think that came up in the first panel, the vision of how much more able a primary care provider is to actually deliver on what they thought they were getting into healthcare in the first place for as the system changes and as we talk about some of the tools that are now available to us and some of the changes that are happening in payment in our community as well.
Any other workforce? Yep.
It's a very, very important question, a very challenging one for our country. As many of you may know, if you look at over the last decade, the number of kids that are graduating from medical school going into primary care has decreased by about 25% in the United States. And so there are less in the pipeline, and we're creating more specialists, and obviously higher utilization in the country. With the Affordable Care Act, there were mechanisms to help mitigate that. For example, the National Health Service Corps dollars were increased in the ACA. Also, there were Bureau of Primary Health Care dollars that will expand primary care. But until we begin, when the average student in the United States comes out of medical school with loans of $150,000 to $200,000 that they must pay back, and their average salary is $140,000, people are making choices that are economic. And we need to balance that at the national level. We need to have higher reimbursement for primary care physicians. We need to have loan forgiveness if you're interested in going into primary care physicians. And we need to increase the dollars for roles and positions within urban and rural communities so we can attract people to stay, who graduate in primary care, to stay in areas of need. So very challenging, and I think ACA has gone a long way to correct some decades of deficits, and I just hope we can keep those dollars.
Two just short comments. What we're actually seeing is that health IT makes primary care more attractive, and that young providers are going into practices that have an integrated system or have health IT. And so if anything, this allows you to attract people into rural areas. INHS is a 14-county part of eastern Washington. It's largely rural and some underserved areas as well. Telemedicine, for example, allows a primary care provider out in the field to do conferencing with specialists in Seattle. And so if anything, I'm very, very hopeful, in fact, that technology will allow us to use what limited resources we have in even more powerful ways, and sometimes shift the care to broader care teams so that nurse practitioners, et cetera, can provide care as well. And the physician is champion and sort of convener, takes a much more sophisticated role in many cases as a result of technology. And so I think we have enough primary care providers. We need more. But technology will allow us to push that out into areas that are clearly underserved.
I just make one quick comment, two quick comments on this. I agree with my colleagues here. The first comment I make is we need to build a health IT workforce because there is a serious shortage of that as we become increasingly reliant on IT in healthcare. The second is that we train our physicians differently now, right? They have work hour restrictions, they have shift work. So they're going to increasingly rely on electronic systems in terms of passing information to other providers, relying on ancillary providers or support staff to go into electronic systems and know about patients, and then passing their care off 8 or 12 hours later to another physician. So IT is going to become increasingly important. It's the way we train our physicians now to rely on those systems, and we're going to need an IT workforce in healthcare.
And I'm going to be a little disruptive, sort of AKA Anish, and say, maybe Detroit has a population that we can start to train in this area, that Detroit could become a sort of hotbed of health IT workers going forward.
We'd love it.
Time for one more question.
Hi, I'm Eva Powell with the National Partnership for Women and Families, and thank you for a great presentation. And I was really encouraged to hear some of the unique ways that you're engaging patients. But patients are the most underutilized resource in healthcare, and so it would seem wise to move forward in the area of accountable care, as well as in health IT, where we know that most patients and consumers are using IT in every other area of their lives, to actually do more to engage them not only in their care but also in process improvement. I'm just curious as to what other ways that you're actually looking at engaging patients in terms of improving the system itself, but then also what kinds of quality measures are you testing that would have a lot more meaning to consumers and patients than kind of our typical quality process measures that we have today?
Good question.
I apologize. When I gave my talk, I'm a really techie person, and I put it up on Google Docs, and we don't have access to the internet in the room, and so that's why I didn't list. I didn't want to imply that INHS was the only Beacon community that is doing patient-centered care. But for example, remote patient monitoring, Central Indiana is doing that. Western New York has some remote patient monitoring 3 of the beacons are integrating patient-reported outcomes and quality of life measures into their EHRs. Southeast Minnesota is using electronic shared decision-making tools. I think five of the beacons will have a patient portal and PHR functionality. Keystone is implementing a PHR that allows patients to actually input notes into the clinical record, much similar to what the VA is doing. And is it Southern Piedmont, North Carolina? They're also piloting, you've heard about the pilot with asthma. And at the program level, I don't know if that one is public yet, but maybe Erin, you want to talk about some of the new initiatives that are going to be happening similar to the Text for Baby project?
There'll be a lot of new initiatives announced later this summer, and we're excited about that. There's always new things around the corner. You know, I'll end with an observation that I spent some time at Brookings as a policy wonk and wandered around DC circles like many of you and heard terms like delivery system reform and healthcare transformation, and I just went along with it. It sounded good, and I assume we need that. But to hear really what it actually means on the ground is what's so encouraging about this work. It's not easy. Dr. Smitherman and others have said that. But you know, for example, last week when I was in Colorado, I went up to one of the frontline folks in a physician practice participating in Julie's effort, and I said, clinical transformation, what does that mean? Give me an example of something you're doing that's transforming something. You know, and she quickly said, well, here's an example. We used to basically take patients as they come. They come in, we figure out what to do immediately, get them out of there 10 minutes later, and hope that it all works out. Now we actually have a meeting the day before the patient shows up, and we look at all the patient information and decide, what does that patient need tomorrow when they come in here? How can we best be prepared if they're coming in for diabetes? What are the other things they need? What about their smoking cessation? What about the other things that they probably are not coming for directly? It was a good example of the hundreds of things that are going to change in practices around the country and in hospitals as we put into motion this otherwise fuzzy concept called delivery system transformation. It's really fun to see it on the ground and to help inform the policy process about the experiences of how hard this is, as well as of the ways that it's easier as you keep moving with your eyes on the prize and your feet on the ground. So thank you all for this great panel, and we're now going to shift to some folks who can help us understand how we're going to sustain all this great work. Right, Mark?
Thank you.